All right. Good afternoon, everyone, and welcome to this live webinar titled Effects of the Global Gag Rule on SRHR, specifically on abortion provisions. This afternoon, we are going to discuss the 4 years of devastating Mexico policy, also known as the Global Gag Rule on women and girls' sexual reproductive health and rights. Now, this conversation is important. Let me explain why before I invite my panel. At the time of the resettlement of the Global Gag Rule in January 2017, 32 countries and 53 healthcare projects worldwide were affected by the Global Gag Rule. Now, this GGR, or the Mexico City policy, denied US funding to organizations and other CSOs providing abortion services, counseling, or referrals in accordance with the national law. It blocked critical funding for services like contraception, maternal health, and HIV and prevention and treatment. Now, evidence from previous policies shows that eliminating access to contraception leads to more forced pregnancies and unsafe abortion. So that's a good place for us to be in. Let's welcome our panel for today. So I'm going to introduce them one by one. Let me start first with Bishop James Okombo, who's the founder network of church leaders tackling HIV. Bishop is a religious leader living with HIV and founder of Network of Church Leaders Tackling HIV and Gospel Parliament, a platform that gives religious opportunity to dialogue on both social and spiritual issues that are controversial, e.g. abortion, faith healing, LGBTQI, condom use, and etc. Currently, he's the Reverend Speaker Sir of the Gospel Parliament in Nairobi, Kenya. We'll be hearing from Bishop and his words of wisdom in this webinar. Also, welcome to Martin Onyango, who's the Senior Legal Advisor, Center for Reproductive Rights. Martin is the Senior Legal Advisor for the Center for Reproductive Rights Africa program. He's responsible for spearheading litigation in Kenya and supporting program strategy on litigation and related advocacy, supporting the development of capacity building strategies, cultivating pro bono relationships, and representing the center externally on issues related to the region. We'll be hearing from Martin as well. Let's welcome Jerop Limo, who's the Communications and Media Advisor, Ambassador for Youth and Adolescent Reproductive Health Program. She also assists in programming and any other role given. Jerop is a 22-year-old sexual health advocate. Is passionate about advocating for adolescents and young people living with HIV. She found herself in the HIV response field for so many reasons, and as a young girl advocating for safe spaces for adolescents and girls, women has always been part of her daily goals. She ensures that the adolescents and young people can access correct sexual reproductive health services and information easily. Jerop focuses on responding to sexual reproductive health needs of young people and offering psychological support for adolescent and young people living with HIV. My fourth panelist is Kennedy Miriti, who's a reproductive health coordinator. Miriti is the reproductive health coordinator for Kilifi County. He's holder of a BSc Nursing, higher national diploma in medical education, and a basic diploma in community health nursing, and a specialty in program management in global health from the University of Washington. Kenneth has a strong background in the reproductive health issues with a bias on adolescent and youth reproductive health and rights and gender-based violence response. Finally, Leila Abdul Kair is the Reproductive Health Network Kenya youth advocate. Leila is the deputy president of the Kilifi YAC and co-founder of a youth-led organization in Kilifi called Power Action Changes, or PAC. She's also a sexual reproductive youth advocate with Reproductive Health Network Kenya. And Leila is a leader, teacher, mentor, and youth advocate of IYSRHR and policy. She's so passionate and advocating on health issues and that affect adolescents and young people in Kilifi County at large. Allow me to welcome all my panelists. Let's start from where we should. Let's start with you, Martin. Could you just give us a brief background to everyone else? What is the Global Gag Rule? You know, if you don't understand it, what does it mean?
Thank you very much, James. We know that every government comes into place, and it comes with its own preferred foreign policies, but also national policies. The same does not escape the United States government. And so before 2017, the US had a policy that largely affected financing for reproductive health within the US. But in 2017, this policy was expanded to then affect US government funding of reproductive health, even to organizations, non-governmental organizations outside the US. So when we talk about the Global Gag Rule, this is a US foreign policy based on prohibiting NGOs outside the USA who are receiving US global health assistance. That is part of US development support, the global health assistance. So the rule prohibits non-governmental organizations outside the US who are receiving US global health assistance funds from using this money or any money that these organizations have, uh, the money they have from other sources, to perform or actively promote abortion as a method of family planning. On the face of it, the rule basically prohibits NGOs outside the US from using money they receive from the US as from the US assistance in promoting, counseling, supporting abortion as a means of family planning. In the strict sense of it, the rule is problematic, but not very problematic. The application of the global gag rule outside the US amounts to one: there is no use for US money on anything, any activity that is related either to abortion or closely related to post-abortion care. And that is it. The application is a total no use of US support or money from the US government in abortion related activity. So that in a nutshell is the global gag rule. The rule itself within the US and its application outside the US in countries that receive the global health assistance is world apart. It's more restrictive, it's more debilitating to organizations that receive the US assistance. And its application has had far much reaching effect right from 2017 up to now that the new administration has actually lifted or revoked the policy.
Thank you, Martin, for that sort of very wide definition, so that we are all on the same page. I think that's a good time to sort of move in and start getting examples, because this is a forum and for young people to find solutions and talk more broadly around what the issues are affecting everyone. Leila, if you could help us, in those last 4 years, how has this gag rule affected young people and the adolescent, and and every other issue that you'd say for for them to access say support from you and material from institutions that were providing these services before? I don't know if Leila can hear me.
Yeah, I can hear you. Thank you so much, especially to the young people in the issue of the global gag rule. It has really affected most in issues of where many young people had unsafe abortions. That really led to a lot of unsafe abortions happening in Kenya. We know that 7 deaths in Kenya are recorded, and most women and girls are dying because of unsafe abortions. And the effect that it has led to the gag rule, it has led to high rate of unmet needs of contraception, especially to the women and girls at the community. And especially to the youths, there is a lot of high, it has really brought the issues of high stigma, especially in matters of reproductive health. reproductive health, since the global gag rule actually depending on so many organizations that can actually help them in taking services and also help them in referral. And the global gag rule has really led to also increase in gender-based violence, especially to the youth. So many cases it has increased, and so many organizations that were actually focusing on issues of gender-based violence, and so many organizations that actually related in issues of abortions. It has really limited even the young people to access services. And what I can also say, it has really made to high mortality rates. It has really increased, especially to the youths, and due to the unsafe abortions that are happening at the community.
Thank you,
Thank
Leila.
you.
Yeah, thank you, Leila. I think this would be great for Kenneth to just bring us in further into this space so that we can, as we try to paint a picture of what these last 4 years look like. Kenneth, since we now know what has happened, and Leila speaks very eloquent about the young people and what has happened and what they've missed for the last 4 years, could you give us specifics in Kilifi, for instance? What has happened in women and girls seeking abortion services? Do we know? Do we have numbers? What has happened in the last 4 years? Do we have Kenneth?
Can you hear me? Can you hear me?
Yes. Please go ahead.
Yeah, so thank you very much for that question. I want to say that currently within actually the Ministry of Health and even the counties, we do not have specific data for abortion, and this is because safe abortion services are not provided in the public facilities per se. What we provide in public facilities is post-abortion care, which I've always said in various forums, that it's like reacting to an already a problem that has already occurred. But that said, the Global Gag Rule has had a big impact on the health of mothers, the girls, and basically women in terms of seeking for reproductive health services. So if I can take you back to 2017, as Mike said, there was a deliberate withdrawal of funding for CSOs and even government entities and anybody that was related to the US government to reproductive health programs. And this had a big impact, especially to the adolescent girls who used, in 2018, actually, there was a big explosion of teenage pregnancies. And this can be associated with the lack of contraception, which from that year, we have seen a tremendous decrease in supply of contraceptive commodities, and actually heading us to put cost on contraception, and also so many restrictions that were given to government entities and also CSOs so that they can get funding. So if you look at the number of women dying out of abortion, girls and even older women, the numbers are high, and this is because of lack of these services in government institutions. And we associate this with the Global Gag Rule in the sense that if a government or an organization is known to be providing safe abortion services within its premises, then the US bodies, that is the funding, the donors from the US, are withdrawn, or the rule provides a room where whoever is providing these services is blacklisted from getting funding from those organizations. And so for me, I would say that the last 4 years have been very hard. We remember in this country, we had the guidelines on safe abortion. That is the post-abortion care guidelines, which were withdrawn at some point. And this was as a result of the same Global Gag Rule. So in short, what we are saying is we are lacking a structured way of approaching safe abortion services within this country, which is again like burying our heads in the sand, because these procedures are done every day. We see them. We see young girls, women, and people who seeking for these services coming after they have procured abortions in unsafe spaces. Yeah. So in a nutshell, for Kilifi County, I'm not able to give the actual numbers of girls who have accessed abortion services because of the issues I've raised in terms of our tools for data collection and also what is acceptable within the public health sector.
Thank you, Kenneth. We will circle back to you and talk more broadly, maybe elsewhere about the country. But let me bring Jerop now. Jerop, we have some clarity and some examples from the abortion side of things. Did this global gag rule affect provision of HIV services, HIV provision services?
Okay, thank you, James. So obviously, as a country, we know most of our funds when it comes to HIV response, be it treatment, be it diagnostics, be it even HIV funded program, most of them, if not all of them, are fully funded by funds, from outside our country. And, most of our funds were even coming in from the US. But when the gag rule came, then it meant that we couldn't access these funds. This altered, service provision, specifically HIV service provision, be it, access to treatment, access to the service itself, access to HIV commodities. This altered a lot, and it actually, dismantled quality and comprehensive HIV service provision in our country, because most organizations that were, receiving the money and ensuring that commodities and services were available to people, specifically even young people, were not able to access these funds. So it meant there was no, higher uptake of HIV services in facilities, because definitely if there's no commodities, if there's no services, then obviously there won't be uptake. So yeah, the gag rule definitely, not majorly as the way it affected, the reproductive health, specifically on abortion, but in terms of HIV service provision, yeah, a big part of the service provision, treatment, and even commodities was affected due to the cut of funds because of the gag rule that was there initially.
Thank you, Jerop. Let me get in Bishop. The whole concept of the last 4 years is that President Trump was pandering to evangelicals and using the whole idea of religious as as a problem, and saying, look, God does not allow abortion and that sort of thing. Bishop, the church played a key role in the US in getting this gag rule sort of get through the administration that has gone. In Kenya, we still have the same issues and the same questions to raise. What would you say was the church response in those 4 years when the gag rule was on? What was happening inside, even as you were speaking with fellow men and women of cloth about the attendant problems that we must solve in terms of providing quality healthcare for our girls and women and everyone else, vis-a-vis what we feel religiously? Is Bishop in? Okay. So let's. I think we can go around the room and let me start with Martin again, and I think everyone else, and sort of start talking about the difficulty of the religious question. The gag rule might now have been abolished, but it still exists, and part of the problem that exists with the healthcare challenges and questions is how the religious and the church folk are framing the problem and the questions that we have. Martin, how do you deal with this opposition, for instance?
Thanks, James. I think when you cite religious opposition to reproductive healthcare in this country, for me, it is just one bit of the problem. And if we look at it in the context of the Global Gag Rule, is what did the Global Gag Rule do? One, it took away money from the health sector, and in particular, reproductive health sector. Besides taking away the money, the next thing it did is that it emboldened opposition. This opposition, emboldened by the pressure from the US foreign policy, included the religious sector, included organized groups that, for one reason or another, oppose one reproductive health care and or the other. The other thing it did that with the emboldening of opposition and taking away the money, policymakers were then intimidated. And so when you see, for example, what is raised that during the ICPD, for example, we saw the US ambassador putting out two op-eds, very erroneous, that the pro-abortion activists were now changing the ICPD targets. But then what that does, or what it did over the 4 years, is to intimidate policymakers so that instead of making progressive health policies for the entire population, there were efforts to intimidate policymakers to shy away from certain reproductive healthcare services. That is abortion, that is post-abortion care, and this extended to contraception at some point. But one thing we need to realize that you cannot divide healthcare. It is very difficult to say that we will only provide maternal health services, but will not provide child care services. We will only provide maternity care services, we will not provide contraception. We will only provide post-abortion care, but for women in need who qualify to access abortion within the law, we will not provide. What then the Global Gag Rule did in emboldening opposition and intimidating policymakers, it tried to create a rift, to create some reproductive healthcare services that were acceptable or favorable, and some that were unfavorable. This is where then the religious discourse come in, that then those who oppose access to abortion within the law then found a fertile ground to then air their opposition, and that opposition is still ongoing. So for me, I would say that opposition by some religious sector, because I do not believe that the entire religious sector is opposed to access to reproductive health care, but it is some elements or some section of the religious sector that is for no reason opposed to comprehensive access to reproductive health care. They get more emboldened when policymakers, when government institutions that have the responsibility to deliver comprehensive health care to the population are intimidated, partly because they're seeing there is no money, or should they champion access to comprehensive health care, they will be denied money. And of course, we all acknowledge that that was a false application of the Global Gag Rule, but that is a reality that we've suffered for 4 years on the ground, that money has been taken away from non-state actors. They have closed facilities. Services at the lowest level at communities that were offered by these NGOs is no longer there. People employed by those NGOs were sacked. As it escalates higher, government got intimidated. Policymakers took a backseat in working on comprehensive policies to protect the entire population. Access to abortion, post-abortion care became more stigmatized, but with the withdrawal of many services and the increased stigmatization, it therefore meant that many women and girls, even those who qualify for abortion within the law, were pushed to quacks. The net effect, as Miriti put it, if we are seeing more severe cases coming for post-abortion care, or many deaths reported of women and girls who then sought unsafe abortion elsewhere.
Okay, let me just go around the room to my panelists to on the same question of what has happened these last 4 years in terms of dealing with opposition that is religious in nature, and how it emboldened, as Martin say, emboldened the opposition and made it possible for, sort of to move this conversation forward. As the ban is denied, that's not the only thing that happened. We also had, on the ground, there were actual things that are happening. So let me just go through the room to pick out your thoughts. And in terms of the question of the religious, opposition, how it's been the last 4 years, and looking forward, how this problem can sort of be solved. Let me start with Kenneth.
Thank you very much, James. I think the issue of religious leaders, the religious opinion on matters abortion and matters reproductive health, I think, to my opinion, it comes out of mostly ignorance and lack of information. And the lack of information was actually, as Martin put it, was eventuated by the Global Gag Rule, because the pro-life and the pro-life activists were able to get a lot of funding to be able to fight what is actually supposed to be somebody's choice of choice in terms of reproductive health. So for me, once we are able to get enough resources to be able to bring on board the religious leaders on these matters, I think it will be a very easy selling. And I've been there before in around 90s when we had problems with the contraception. Actually, you would not talk about condoms on television. You remember very well, James. It used to happen that anybody who is championing for contraception was seen to be a bad person. But with the change in global perspective of contraception and family planning, then most religious leaders actually have been able to embrace contraception, and we have actually various religious organizations that are doing very well in terms of contraception. But the question that lies that goes to each of these leaders is what is the divide between maternal health that concerns deaths that are coming from abortion and deaths that are coming from childbirth? Because for us who have worked in this space for a long time, we know very well that once a woman is pregnant, any woman who is pregnant, their chances of survival are, we have a 50-50 chances of survival from that pregnancy if it is not handled well. There is no divide that says that you are not supposed to provide clean services, good services, quality services to people who come for various services, reproductive health services, including abortion services. But now the notion that has been created, and this is through the resources that Martin is talking about, a lot of resources pumped to ensure that some of these things do not see the light of day in terms of sensitization of communities and maybe religious leaders, religious groupings, in showing them what is there, what is actual on the ground. It brings a lot of problems. Then I want to talk about the issues, the government policy on abortion. If you look at how we have handled the abortion data, the age disaggregated data, it's not the same way as other services, and this has also created a big problem, because for you to be able to convince the government, to be able to convince religious leaders and even other community leaders, including the CSOs, on the effects of a certain parameter of health, then we need enough data to be able to support some of these issues. But what are we seeing? We see us collecting data, reactionary data from in the DHIS in the form of post-abortion care, meaning we are not concerned about the person before they procure an abortion. We are concerned about people who have already procured abortion, who have come with complications of abortions. The data we have, the national data we have on abortion is actually from people who have already had complications, who come to our health facilities to seek for those services, not people who come for services, the abortion services, who have either accepted the services or maybe they have been cancelled against the service. So that is the biggest problem we are having, because if you look at, for example, maternal mortality, if you look at, actually, if we were to balance between maternal mortalities that are occurring in our maternities and the deaths that are occurring on the streets, in the back street, and also in our hospitals in terms of abortion complications, then you realize that a death for abortion and a death for a woman who is delivering who is having their babies in hospital is not any different. A mother has been lost. A maternal mortality has happened. But what are we getting with the Ministry of Health and also at DHIS in health facilities? We are only getting women who die when they're giving birth, not women who die when maybe after procuring unsafe abortions, or after maybe even on safe abortions, where we are supposed to get this data and be able to interrogate and say that surely this is a problem that is occurring and this is a problem that needs a lot of our attention. When we had a lot of teenage pregnancies, just recently, a lot of organizations, government institutions, the counties have pumped a lot of resources towards reduction of teenage pregnancies. In the same way, we ought to look at how many women in this country have lost their lives because of abortion. How many women do not have an ability to ever get a child again because of a mistake they made some times back of going for a backstreet abortion, because those services are not offered in public institutions and also in other institutions that are gagged to provide these services. It is the this is the early time that we need now that the gag rule is lifted. It is an early time that we need to talk to government institutions, to talk to religious leaders, to talk to all the lobbyists, to ensure that people understand that we are not championing for people to kill babies. We are championing to save the lives of mothers.
Sorry, my microphone was on mute. Let me head to Jerob and just on to the same question, to reflect on the question of the religious response and opposition, and especially in provision of health services. What the last 4 years has sort of taught you or showed you, and sort of to look forward and look in the future, what you expect on this particular point.
Thank you, James. First, I think as a country and even as young people, we're in a place where, and I've seen someone has commented and mentioned, it is high time we just put aside the religious aspect when it comes to health, because these are people's lives we are bargaining and debating about. And the worst thing about this is, at the end of the day, whether we agree with what the religious people say or not, then it means there are people who will suffer. Let me make an example of HIV services provision. Obviously, we are a religious country and we have religious people. But when it comes to entity, when we want to do things and the religious, group or the religious, leaders try to hinder that from happening, then it creates a barrier for young people, for even the general population to actually access information. And it has been mentioned, it could either be ignorance, it could either be, lack of information. And even for some of them, it's the fear, I have worked with religious leaders before. We are trying to ensure that the conversation around sexual reproductive health and rights is included even in the church setup, because we want to ensure that our people actually have access to correct information. That is how we are able to make right choices. So the aspect of religion, it's something that is going to take a lot of time to change, a lot of advocacy to shift their thoughts. We also saw when Senator Kihika was pushing, the abortion bill, not necessarily the abortion bill, but that is how they decided to name it. and people were calling her names and saying, she's pushing for young people to actually have sex, to kill children and everything. But at the end of the day, no one actually thinks about this specific girl who is not ready to give birth, who is not ready to be a mom, financially, emotionally, physically, in every aspect of their lives, and they're not ready, and they want the opportunity to decide for themselves. Just because maybe they're below 18 doesn't mean that they don't have a choice to make for themselves. They definitely do, because at the end of the day, I am the one who will be taking care of that child. You won't be there. So if you deny someone access to, abortion when they feel like that is the right choice for them, then that is a problem. Okay, if we allowed the availability of access to reproductive health and services, contraception, then we wouldn't be having the conversation around abortion, because now young women will have access to contraceptive, and they know if they're engaging in unprotected sexual sex, then definitely they have access to contraceptives. Then it hinders the issue of, unwanted pregnancies and unplanned pregnancies. Then we wouldn't be having a conversation of abortion. So the aspect of religious leaders, it is something that, has really hindered a lot of progress when it comes to young people accessing services, information around reproductive health and rights. But we are hoping, even as we proceed, and even with the gag rule being repealed, we are hoping that a lot of conversations will go on. More outreaches will be there to reach to young people, more conversations, even with the religious leaders, just to ensure they have access to information. They get to understand why this is important. Maybe for some of them, they don't understand why abortion is important, or why reproductive health is important. If the shoe fits, if you want the shoe, then you might understand why it is important. But for some of them, they don't understand. They look at the Bible aspect, but yeah, the Bible exists, but the reality of things is very different. Schools opened, and so many girls were not able to resume back to school, because some of them got married off, some of them were pregnant, some of them due to complications around reproductive health. Some of them, we lost some of them because of, unsafe abortion. And the truth is, every day, even right now as we speak, a girl somewhere is going through an unsafe abortion, simply because they can't have access to these services, something that is very crucial for a lady, or even for our boys. So I feel like it's high time we call a spade a spade. Make them understand why this is important for us. Fine, if you don't want to access the service, no one is forcing you. But we have so many women who want to access these services, so many men who want to be involved in this conversation, but because of the religious, umbrella and aspect, they sort of, shy away from the conversation, which is something that we want to shift, we want to change. Yeah.
Thank you for that. Very great wide concept on what's happening with the religious and young people. But let's also bring in Leila's voice into this as a youth advocate. The same question on the difficulties, if any, that has been experienced with you that you can share with us, on how the religious as an opposition has been emboldened in the last 4 years and made it your work difficult, the work of young people to access, health services also difficult.
Yeah, actually, the issue of religious leaders, it has been a very great challenge, especially to the youth in the community when they're accessing health services. One thing that I can give an opinion that most of these religious leaders, they don't have inadequate information. Some they don't know what family planning is. They don't know what are the services of the reproductive health that the young people need. They are just sitting there. They just actually judge. I think you find that most especially the women, some they don't go to the facility. You see that it's already limiting the woman or the girl accessing the services. You find that most of them, they don't want even to access the contraception. And even we had an incident where a religious leader actually denied they actually denied a young person to access services. They were actually judging. They were saying, oh, how can a young person going to in the aspect of the culture and also in the aspect of the religion. I think it has been a very great challenge. And what I can also say that if we bring board the religious leaders, when actually the global gag rule it has been repealed, I think it is where we have a collaborative approach where the religious leaders come close to the young people, get to hear what the young people are saying, get to hear what actually the services that the young people need. That collaborative approach can also help them when the religious leaders, even they are being capacity built, they already know what is going on in the aspect of health in the young people. I think this is the time that the religious leaders should come out and be champions to the young people, especially when we are talking issues of reproductive health, even in access of safe abortion services.
Thank you. So someone has said on our comments, thank you for that, Leila. That's very eloquent. Someone mentioned and commented in our comments and comment section, and they say the reason why the global gag rule was effective in the first place is because we do not have local resources that goes towards our health services, if you like. And that is a big question. I don't know, Martin, if you want to start handling that, the question of getting donor funding to deal with our most immediate problems. It says something about our society, says some things about our government. How do we answer to that question?
Thanks, James. And I think the viewer has hit the nail on the eye, because global gag rule affected Kenya and other poor countries. One, because of our model of health financing, is that our health sector is largely financed by development partners, so that when policy changes, when those countries change their priorities and their specific policies on how they handle their foreign development or aid for that matter, then we get affected. So to deal with or to minimize the effects of change in foreign policies of countries that traditionally support development in health in poor countries, it beholds our governments to then prioritize financing health, and more so primary healthcare and reproductive healthcare for that matter, so that the very primary needs of our population are financed by our own resources, and we do not have to rely on resources from other countries to finance the very basic of healthcare that we need. Because should there be alteration in foreign policies that are bound to occur when governments change, then our populations get affected and they get to suffer, just as we've seen in the past 4 years, the impacts of the global gag rule. But then it really calls on governments to implement the Abuja Declaration. Let us uphold financing healthcare to a minimum of 15% of our national budget, so that the basic needs of our populations are financed by our own taxes, are financed by our own resources. Then we cushion the population from those external factors. We've been talking about universal health coverage, and you see these discourses are not delinked. When we are saying we are providing packages to provide primary health care to a majority of our population, so that we limit out-of-pocket spending for health, what are we prioritizing in those packages? What services are included? If we really want to protect women and girls, men and women in this country, reproductive health care must be provided as part and parcel of the essential package under UHC. That is one of the surest way of guaranteeing our population that should there be changes in foreign policies of those who traditionally support healthcare through state and non-state actors, then we will not suffer adverse effects.
I'll pick it up from there and take it to Jalimo. Do young people specifically have proposals on how our policy in healthcare works? We're talking about UHC that Martin is bringing on board. As the gag rule has been repealed, but what proposals do you see, and to what extent do you think your young people can sort of try to push or find a different mechanism, if any, to sort of start moving the conversation forward on how exactly do we get the healthcare we need? The Abuja Declaration, for instance, is one of them, and we have, there's always politics, and healthcare is part of the politics. How do you get young people to get involved and sort of do more?
I think, thank you, James. So I think one of the ways to get young people to be involved in these spaces is spaces as this, spaces like this, where as a young person, I get to share my insight and my view, on some of these issues. As young people, there are a lot of ways we have been trying, to push, to advocate, especially for primary funding, leave alone funding from development partners, our own funding. I'll give an example. If right now, for instance, if PEPFAR and Global Fund, all those funds we receive from development funders, if they decide today they're not giving us any funding at all, trust you me, when we talk about the 1-point-something million Kenyans living with HIV, then all of them will be stranded. That is number one. Every facility that is supported, all the clinicians that are supported by donors, all the facilities that are functioning because they rely on funds from outside, then that will mean that all these facilities will have to be closed down. So as young people, it is high time we took up spaces, spaces where we air our voices, where we air our issues, because no one is best positioned to represent us but us. We need to help to make sure these people actually understand why it is important to invest in health. We need to ensure, our religious leaders understand, why it is important for them to support reproductive health and rights conversations, even in the church setup. We need to ensure that our leaders, when they sit down to budget for their different counties, that they actually budget specifically for reproductive health and rights. Because in all honesty, there's no moving forward if we don't address the issue of reproductive health and rights. There is no moving forward. We will still be seeing the same issues of, teenage pregnancies, the same issues of unsafe abortion, and the losing girls on unsafe abortion. We will still be seeing about the issues of girls not being able to access sanitary towels, for crying out loud. Something like a sanitary towel is not something that any girl should lack. So as young people, there are a lot of spaces, there's online advocacy, spaces like Twitter, where we push for these conversations. We have, the technical working groups meetings that we can join in to push for agendas that relate, to young people. There are even opportunities to actually apply for conferences, to attend some of these discussions, just to ensure that we hold our leaders accountable. Last year, we had the Reproductive Health Conference, and we were trying to follow up on all the, promises that our president made in regards to the ICPD 25. And we want to ensure that these promises are actually actualized. They're not just there on paper. So as young people, there are many spaces where we can take up, as long as we have the information, as long as we push for what we need as young people, then we might be able to make a change. But one of the major aspects is ensuring that there is sustainability of these programs. In all honesty, the gag rule coming in, first of all, we were caught pants down because we were not even ready, and then COVID came in, and then things even became worse. Service provision became poor. Service uptake became poor. There were no commodities. With all the limitations being there, other services were actually even forgotten. And, with lack of funding, there was no much we could do. So as young people, it's high time we push for sustainability. Our government has money. They can actually fund, some of our programs. And, as young people, it's high time we take up these spaces, advocate, attend, the allocation budgeting processes in our counties, in our sub-counties, so as to push for the agendas in regards to reproductive health and rights.
Thank you for that very eloquent this points of view and putting them across, and this is sort of pushing us the story forward and our conversation forward. And Kenneth, you spoke earlier on about government policy and how it needs to be expanded and the restrictive nature of it as we speak today. Here's just another point of how exactly do we get our policy wonks in government business today to be in tandem with what is the reality on the ground. How do we bridge the gap? Because we seem to be talking about this, we seem to always be missing the point. You always sometimes seems to be speaking at cross purposes. How do we get the people who are running government and policy makers to be in tandem with what's happening on the ground, with what Jalim was talking about and what Leila is bringing up to the table today?
I think we need to start from small to big. Remember, this conversation is a very emotive conversation, and looking at the country landscape on reproductive health, particularly the reproductive health bill that has always stalled in midway. We need to start from service provision level. That's in my own opinion, where because the Ministry of Health is capable of coming up with policies. Then at HIS level, that the health information systems level, we need to have data, deliberate collection of age desegregated data for abortion, and not post-abortion services. It's actually abortion. So if somebody gets to a health facility seeking for abortion services, we need to have age desegregated data, which talks about clients who came, for example, for services, clients who are offered the services, clients who are cancelled on various other options that there be for maybe to maintain their pregnancies, etc. Because what we are seeing is where me as a government official, I'm not able to give you the correct information because I'm not deliberately correcting it. These people come to health facilities. Health facilities, both private and government, are obligated to give information on what services they are offering, so that at the end of the day, then when we have a conversation on do we offer this service, do we legalize, do we not legalize, for example, in fully, do we have facilities that are offering these services? How are we supposed to handle these issues? When we come to that policy table, we have evidence, because what we are lacking mostly is evidence, and the problem is actually we have blended that part of the desegregated data collection, and when it comes now to convincing the policy, where we have public participation, it becomes very hard to be able to tell people that actually last year this number of women died in the country out of pregnancies, and the sizable number of them have died out of abortion and post-abortion complications resulting from, for example, lack of the services or all those things. So that's where we need to start from. The other area we need to the other thing we need to do is what we are doing right now, and that's in big platforms, starting from a platform like this one, going all the way to actually mainstream media, being able to invite service providers who and people who are passionate about saving life, who are passionate about giving these services, to be able to speak out to the world. Because information that is covered, like a candle that is covered cannot give light. We need to be able to come to media and tell the public what is actually on the ground, that things are not as we see them. By the way, James, there is something that always puzzles me. When a religious leader wants services, these services that I'm talking about, abortion services, they'll go to health providers and they of course express themselves and ask for the services. But when they go to church, they will never say that they sought for those services. Because I have people who have ever come to me. Of course, you can't divide the names of people, but I have people who have ever come to me seeking for those services. Maybe they have heard that mess here and there maybe a sister or a person in the church is having those issues and they want to be sorted, they will always seek for those services. But talking about them becomes a big problem to them because the conversation has been that this is seen, this is something that cannot is not allowed in the society, and it cannot be it cannot be talked. People cannot talk about it in public. So we need to demystify the messages out there. We need to get more platforms that people can get information on that we have facilities that are offering safe abortions. We have facilities, government facilities that you can get these services. All healthcare providers, me included, all of us are trained on how to assist clients who come with the problems with problems of abortion. But now the problem comes in when we have stigma for our service, and this has been created as a result of what we are not collecting this data. We cannot actually tell how many people are seeking for the services simply because we have deliberately blended the space of data collection. James?
Thank you, Kenneth. Which brings me to the point that I was going to very well take to Leila. The question of stigmatization of SRHR and the intolerance as an opposition and our religious views, our cultural views builds up to this what we have today. So we have a problem of healthcare that is sort of clothed in so many of our perceived problems as a people. From your perspective and experiences as a youth advocate, first question is how do we deal with that? And two, what has it been like? Has it been progressing? Has it been increasing? Is it getting better?
James, can you hear me?
Yes, I can hear you. Go ahead.
Can you hear me? The aspect of stigma, it has really been a great challenge, especially to the youth, when you are accessing safe abortion services. Especially when the women and girls at the community accessing the abortion services, the stigma starting from the community. Let's go from the community side. You'll find that especially those women who actually have had abortion, the society now, they actually discriminate them. They say, okay, you are a young girl, you have actually done abortion, so how can you be part of us? And most of them, they really feel discriminated, and some of them even they don't want to know what has happened to this girl, what has happened, and they don't want even to follow up what is happening to this girl. And when you go to the issue of stigma, when you go outside we go to the facility now, young people right now, even they don't want to access even the abortion. Yes, they want to access the abortion, but they don't know where they can access it. And we have collaborative approach with organizations that like Reproductive Health Work Network Kenya can also come in. You have the Nena na Binti where you can call. I think that collaborative approach, the issue of stigma, it has really reduced at the facility now. And you can see that especially when you go to the community, most of those youths, they don't want even to go and ask. They live in fear. First of all, they say like, okay, when I go to the facility asking for some abortion just because I've made my choice, the nurses can be judgmental, even the people around can be judgmental, even the friends around can be judgmental. I think it has really been a great challenge. And I can also say the reduction of this stigma, it should really have to work the aspect of collaborating. And to reduce this stigma, the civil society organization, especially the community, the religious leaders, should come together at the community, especially at the grassroots, whereby these young women, these girls who are there, even they don't have information on where can they access services, and most of them even they don't know what are the safe practices that they can go to access abortion. Some of them, they have a lot of unsafe abortions that are happening, and mostly they can't come to the services. the facility and they can't even say whatever is happening to them. That's why there is need to have a collaborative approach where we can also reduce stigma.
Thank you, Leila. That's very eloquent. Martin, I hear what Kenneth was bringing on board on the question of data and statistics. It's an important bit because policy is informed by data, of course. But then we know this country with data protection and laws and how it's not worked for people before, for instance, like reporting a crime in police station, and we have the people who are actually victims getting, victimized because they report a crime. How do you deal with the question of data? As much as we know it's important that we need to know what's happening in our communities, with the situation we have, with the securitization of, all health aspects. How do we go around that as a problem?
Thank you, James. I think putting in place a framework for adequate data collection is data collection on health is a primary responsibility of government, and in particular national government for this matter. And a good look at the Health Act of 2017. It provides room for the minister or the cabinet secretary for health to then put in place several regulations, and those include frameworks that would allow collection of disaggregated data on all health services. And when we talk about one particular health service, when we are talking about abortion care within the law, the Health Act actually requires provision of abortion to be a notifiable condition, that when a facility or a provider provides abortion within the law, they then need to have a framework for notification. Meaning that they notify a central point designated by the Ministry of Health in the form of data collection processes, that these are the services we offered to the population. Records or information of health is protected information. No health care provider is allowed to divulge to third parties information regarding a patient's health unless the same is sanctioned by a court or that information is volunteered by the patient, him or herself.
Thank you. I don't know if we lost Martin, but I think we did lost Martin. Martin, are you back?
Can you hear me?
Yes. Sorry, we lost you there for a bit, but go on.
Oh, sorry, I was saying that protection of information, a patient's health information, is already protected under the Health Act, and it is information that can only be divulged by the patient, or if there is a court order allowing the provider or the facility to release that particular information. So there is legal that the Ministry of Health should put in place a framework for collecting that information. However, we are suffering in an environment where we still do not have the regulations, but also the protection of health information is more observed in breach. That in some circumstances you find this information is revealed. So the solution from my perspective is we need adequate awareness, one, on protection of health information, two, on protection of data collected from individuals, including patients, as provided by the data protection law. But then also, we then need the Ministry of Health to put in place the framework for collection of that information that will then be subject of that protection, and only to use it as allowed by the law, and not to use it either to stigmatize or to restrict certain healthcare services within the country. Thank you.
Martin. I want to start winding down now, and I'm going to start with Leila and asking everyone the same question. Now the global gag rule has been repealed. What next? Leila. Leila, can you hear us?
I think Leila is trying to speak. She's not just coming through.
Well, it
Hello?
appears Leila has some. Yeah, please. Can you
hear me?
hear us? Yes. Please go ahead.
Yeah, I can hear. Okay. So when this global gag rule has been repealed, what is next, especially for the young people? It's by ensuring that there will be a prioritization of comprehensive abortion care, where young people can actually access services, where young people can access non-judgmental services, where young people can also be there to access the issues of the safe abortion services. It's whereby the young people, especially the women and girls in the community, can also know their rights. They know what is going on, and they also know what is their health choices, that they can be there. I think it's time that we really need to build the aspect even in reduction of teenage pregnancy. We also need also to have the collaborative approach where we can also help the young people to access services at the facility. That it's something that is very crucial, where young people can access services that are there. The people who are living with HIV can access services that is non-judgmental. Young people, especially the women from the grassroots, the facilities that are nearby where they can access contraception. I think this is something that we really need to have the aspect of comprehensive and also a prioritization of abortion health care for the youth.
Thank you very much. Kenneth, same question. The global gag rule has been repealed. What next?
Thank you. I think it's a full plate for us. Those of us who are in this space, especially the reproductive health space, because first and foremost, James, what is happening currently is so many organizations that have not been providing these services are approaching us to support in terms of capacity building of healthcare providers, support in terms of dissemination of information, etc. And that means that going forward, we are going to, as counties and government entities, we need to actually open up the space for partners who are coming in support of this service. So for me, I would say that first and foremost is for partners and government entities, we need to develop strategies that will ensure that these services are well documented. The services that we provide, whether post-abortion or otherwise, or even actually even counseling on abortion services, counseling on alternative methods of abortion prevention, these services are documented, so that we are able to know now what levels do we need, or what areas do we need to do intervention. And the other one is what I mentioned earlier, that we need to bring the abortion data very well in HIS, because that's where we have this information actually going to the public and informing policy. So a conversation need to ensue between the counties, the Council of Governors, the Ministry of Health, the CSOs that work within the space of the SRH space, to ensure that we are getting this done as soon as possible. And then mainstreaming of abortion services within the public sector, where people who come to seek for services can actually get these services, as opposed to them being referred to quacks and then coming back again for post-abortion care with complications. Of course, adding abortion services into the MOH spectrum, and this I mean the dashboard, where we have the RAMCA dashboard, will go a long way in ensuring that we're able to compare counties, to compare various geographies on what are the service needs for those areas, and eventually be able to have enough evidence of why we need to have these services actually funded by the government. And finally, we also need to have a national conversation. This goes to the media personalities like you, James, and the rest, so that people can understand what is there, what windows are there, what is this window that is there that has been blinded by the global gag rule. But going forward, I see a lot of capacity building for healthcare providers, particularly I'm talking on behalf of Kilifi County. We are looking forward to partners people who can partner with us to ensure that our healthcare providers are trained on these services. Now that there's no restrictions, the future looks bright for people working in this space. Thank you.
Thank you very much, Kenneth. Jerome, very same question. The global gag rule has been repealed. What happens next?
Okay, thank you, James. So obviously we are looking forward to better service provision, commodities availability, and even shifting the conversation of reproductive health and rights from the facility to the community. Obviously, if it's high time, there is a major gap when it comes to access to information, and that's why we're facing some of these hindrance from the community and even from the religious aspect. So we are definitely looking forward to shifting the conversation, not only from the facility and taking it back to the community. We want to do away with some of these misconceptions and harmful traditional practices. We definitely want to change the conversation and make people understand why reproductive health services is important, why even comprehensive sexuality education is important even for the younger ones. And number two, when it comes to HIV, we are looking forward to better services, easy access of commodities, availability of diagnostics commodities, and even testing commodities. And we are looking forward to ensuring that everyone who is on care is actually retained on care. Everyone who is on care has easy access to supportive programs, and definitely we are looking forward to ensure that our government actually upholds and funds some of these things, because with sustainability, then we can't say simply because the gag rule has been repealed and we need to sit back and be comfortable. I feel like we need to even do more, make the government aware of why it is important for them to actually take up some of the responsibility, fund and budget for reproductive health and rights, support clinicians, support facilities. How do they ensure facility is youth friendly? So we are definitely looking forward to doing a lot of more advocacy in ensuring the government actually takes up the responsibility of funding health in Kenya. Yeah.
Thank you very much, Gerald. Martin, the final question, and just to obviously take us home. Very question: what happens next? Massively important, but we have not finished dealt with all our problems, in spite and despite of the gag rule.
Thanks, James. I think now that the gag rule has been repealed, it means that one, we are going to see more the USAID, more resources available from that end for health, and in particular sexual reproductive health in Kenya. With availability of resources, availability of additional resources, then we need to have a conversation. Where do we use these resources? How do we prioritize the use of these resources to plug in areas that have been left behind in an attempt to catch up or to fill the void. This calls for a lot of public participation, public information. It calls for a lot of government accountability so that both county and national governments become responsive, one, in planning and assigning resources for health in light of the additional resources that will come either through partners to the various government levels or partners directly implementing activities. We also envision there being no policy hesitation towards ensuring there is complete access to the broad spectrum of reproductive health. We know that there's been a lot of hesitation to deal with access to abortion care in this country because of the global gag rule and the hesitation that financing may be withdrawn if government departments are seen to be pro-choice or active in that line. I think with the repeal of the global gag rule, we look forward to a more progressive Ministry of Health, to a more progressive county departments of health in engaging the population, in engaging with non-state actors, just to ensure that they offer comprehensive reproductive health care in their counties. CSOs also need to re-strategize and reorganize themselves. Those that shut down, that may restart operations, must then now align themselves with the current environment and just ensure that they fill in or they plug in the gaps that existed throughout the 4 years that the global gag rule was in place. But as already said by my colleagues, it's a wake-up call to government to play the role of government and ensure that health financing is prioritized and we reduce the burden of healthcare on the population by ensuring UHC factors in reproductive health as core components of universal health coverage. Thank you.
All right. Okay, thank you. I want to thank all my panelists who've made time this afternoon to discuss all these matters and all these issues. Jerome, Limo, Stanwell, bringing the issues of the youth into perspective. Leila, you've been great on giving us very great components of what's happening in the space of youth advocate. And of course, Kenneth, from the county government policy perspective, Martin has helped us to condense all these issues from legal issues and the environment that we are working and we are all living in. So this conversation, as always, can continue, but I want to thank you all very much. Thank you all for your questions. Thank you all for making time this afternoon. We should have these conversations periodically. I agree with everyone that this should be mainstreamed conversation. Thank you very much to everyone. That is the end of our conversation today. We promised everyone to 3:30 to 3:32. Thank you all. My name is James Smart. Thank you for having me.
Thank you.
Call is very important to us. Please stay on the line and you'll be transferred to the next available agent.